Welcome. In this session, we are going to start discussing prechiasmal lesions, and prechiasmal lesions will take 3 sessions to cover. In this session, we are going to take a very short overview of optic neuropathy and discuss papilledema and inflammatory optic neuropathy. So, prechiasmal lesions characteristically present with unilateral involvement. But if the lesion is bilateral, if the prechiasmal lesion is bilateral, then we can have a bilateral involvement, and the symptoms and signs include diminution of vision, alteration and loss of color vision, RAPD in unilateral or asymmetric bilateral involvement. So RAPD occurs in unilateral involvement. It can also happen in bilateral involvement if the bilateral involvement is asymmetric, and ONH appearance can be normal, edematous or pale. Visual field defects arising from prechiasmal lesions can be varied, and they depend on the specific nerve fibers which are involved in a particular situation. So the defects can be one or a combination of any of the following. If the papillomacular bundle is involved, we can have a central scotoma, a secocentral scotoma, or even a paracentral scotoma near the fixation. If the arcuate fibers are involved, we can have an arcuate scotoma, a paracentral scotoma, a nasal step, sedal scotoma, or an altitudinal scotoma, which is actually a very broad arcuate scotoma involving either the superior half or the inferior half of the visual field and respecting the horizontal meridian. Nasal fibers can cause a temporal wedge defect, and displacement of the pRNFL by ONH edema results in an enlarged blind spot. So there is a list of causes of optic neuropathy which is quite important to remember. So first of all, we have glaucoma, which will be dealt separately as a broad topic. Then we have compressive lesions, ischemic, inflammatory, infective, trauma, hereditary, congenital anomalies, radiation neuropathy, toxic neuropathy, neuropathies from nutritional deficiency, and optic disc drusen. Starting with papilledema. So papilledema is a bilateral optic nerve with edema from raised intracranial pressure, and these two conditions, bilaterality and raised intracranial pressure, must be satisfied to label the presentation as papilledema. The edema starts in the superior and inferior sectors and then involves the nasal and temporal sectors. We might remember that the superior and the inferior sectors are the thicker sectors. Now, features of raised intracranial pressure include transient visual obscuration lasting for seconds, which may be unilateral or bilateral. So very short lasting visual loss, and these transient visual obscurations occur with changes in position, when the position changes from lying down to sitting or standing. Another feature of raised intracranial pressure is loss of previously documented spontaneous venous pulsation, or SVP. So if we have documented SVP in a patient and on future follow-up we find that SVP is missing, we can interpret that finding as due to raised intracranial pressure. However, if we fail to detect SVP in the first presentation of a patient, that does not mean that the missing SVP is due to raised intracranial pressure, because 20% of normal population does not have SVP. The other features of intracranial pressure are the well-known headache, more in lying down position in early morning and on exertion, nausea and vomiting, and back pain. So the causes of raised intracranial pressure include idiopathic intracranial hypertension, cerebral venous sinus thrombosis, intracranial space occupying lesion, hydrocephalus, and meningeal infection and infiltration. In an early onset papilledema, visual acuity, color vision, and pupillary reactions are normal. That means that the axons are functionally intact. However, visual field examination may show an enlargement of the blind spot. In a chronic papilledema, there is axonal loss, which is reflected in visual function abnormalities and onset of disc pallor. The visual functions which appear abnormal are loss of color vision, RAPD if the involvement is asymmetric, Visual field defects, usually arcuate or peripheral constriction, and eventually there is a decline in visual acuity. Also we'll find gliosis of the retinal nerve fiber layer, which appears like a thin membrane with vascular sheathing, and we find opticociliary shunt vessels, which arises from the raised ICP because of central retinal venous obstruction, which leads to dilatation of pre-existing venous channels on the ONH surface, which in turn drain into peripapillary choroid. So we have these vessels which connect the retinal veins on the disc with peripapillary choroid, and these are called the opticociliary shunt vessels. We can also have refractile bodies on the surface of the optic nerve head, usually along the ONH margin, but they are non-calcified in contrast to optic disc drusen. So this is a picture of a bilateral chronic papilledema, and we can see the gliosis of the peripapillary nerve fiber layer very well here. So we have staging of papilledema and grading of papilledema. In staging of papilledema, early stage is represented by swelling, hyperemia and blurring of margins associated with RNFL edema. In a fully developed papilledema, we have gross elevation of the ONH, venous engorgement, hemorrhages and retinal choroidal folds. In chronic papilledema, the cup gets obliterated. We will have hard exudates in the peripapillary retina, and hemorrhages and hyperemia decrease. In late papilledema, the swelling subsides, the pallor increases, there is arteriolar narrowing and vessel sheathing, and there is also gliosis of the PRNFL, which leads to a dirty appearance. So this appearance is said to be a dirty looking disc. Grading of papilledema by modified Friesen scale. Grade 1 is a C-shaped halo with sparing of the temporal sector. Grade 2 is a circumferential halo. Grade 3 is obscuration of one or more major blood vessels leaving the disc. Grade 4 is obscuration of major blood vessels on the disc, and grade 5 is obscuration of all blood vessels on and leaving the disc. Coming to differential diagnosis of papilledema, the first is pseudoedema, and this is very important. Pseudoedema is represented by optic disc drusen, and in optic disc drusen we have a lumpy bumpy disc with elevation. However, in pseudoedema there is no congestion, so no hyperemia and no vessel engorgement. Also there is no obscuration of vessels, there is no leakage of fluorescence, and there is autofluorescence, that is the optic disc drusen autofluoresce. So we have a lumpy bumpy disc here, but the vessels are not obscured at the margin of the optic nerve head, and this shows autofluorescence of optic disc drusen. In the differential diagnosis of papilledema, we also have other causes of ONH edema, which can be categorized as primarily optic neuropathy and primarily retinopathy. Among those with primarily optic neuropathy, there is papillitis, compressive lesions in anterior orbit including thyroid ophthalmopathy, AION, acute ischemic optic neuropathy, and other entities primarily affecting the optic nerve, such as toxic, trauma, radiation, and ocular hypotonia. ONH edema may arise also from entities which are primarily retinopathies, such as CRVO, papillophlebitis, malignant hypertension, and diabetic papillopathy. We must never forget malignant hypertension, which may be fatal. So how to work up a patient with bilateral optic nerve head edema? We should do a B scan, which may show a widening of the intraorbital optic nerve, and this width decreases with prolonged lateral gaze, called the 30-degree test. Then we should do urgent brain imaging, and this is a must. We should do an MRI of the brain and orbits with contrast to rule out space occupying lesions in the orbit or in the intracranial cavity, and we must do an MR venography to rule out cerebral venous sinus thrombosis. If these imaging results are normal, we should do a CSF analysis to check the opening pressure and to analyze the composition of the CSF. Idiopathic intracranial hypertension is one of the primary causes of raised intracranial pressure, and we find signs and symptoms of raised intracranial pressure such as headache, nausea and vomiting, and transient visual obscuration, along with unilateral or bilateral sixth cranial nerve palsy, pulsatile tinnitus, but no other focal neurologic abnormalities. We will see later that unilateral or bilateral sixth nerve palsy with raised intracranial pressure is non-localizing. It does not lead us to localize the lesion. So in imaging, we do not find any space occupying lesion, neither do we find vascular, inflammatory or infective lesions. There is no ventriculomegaly as may happen with hydrocephalus, and we find flattening of the posterior aspect of the globe, distension of perioptic subarachnoid space, tortuosity of optic nerves, a partially empty cella, and collapse of transverse sinuses due to the raised intracranial pressure. The opening CSF pressure is more than 25 centimeters of water and is done only if imaging results are negative. If imaging results are positive, we must never do a CSF tap. And the CSF composition is normal in idiopathic intracranial hypertension. IIH occurs predominantly in women and obese patients, and it is found to peak in the third decade. Pediatric IIH patients may not show obesity or sex predilection. So intake of certain drugs can cause IIH, like vitamin A, very important, doxycycline, very important, and steroids, both their use and withdrawal, and OCPs, very important. IIH has also been shown to be associated with sleep apnea, COPD, that is chronic obstructive pulmonary disease, chronic renal failure, and anemia. And in these situations, it is sometimes called secondary intracranial hypertension. How do you work up? As in papilledema, and we have seen that in any case of bilateral optic nerve edema, an MRV or magnetic resonance venography is important, because an important DD of IIH is cerebral venous sinus thrombosis. This is also very important to remember. And this presents with signs and symptoms of raised intracranial pressure, and risk factors of cerebral venous sinus thrombosis include OCPs, dehydration, mastoiditis, trauma, connective tissue disorders, and other thrombotic disorders. So coming to treatment with IIH, patients with visual field defects or chronic headaches or having severe papilledema and RAPD require treatment. After the subsidence of IIH, non-ICP headache may persist, and these non-ICP headaches may be migraine or cluster headaches. Weight loss is an important component of treatment, and medications include acetazolamide and topiramate. Topiramate controls headache, reduces appetite, and also inhibits carbonic anhydrase like acetazolamide. So it has multiple roles. However, topiramate in ophthalmology we know can cause acute angle closure glaucoma. Steroids should be avoided as steroids cause weight gain, and steroid withdrawal causes rebound ICP rise. But if you have a fulminant IIH causing vision loss with severe papilledema, it may need pulse steroids to control rapidly. Surgery is indicated when medical therapy fails or is not tolerated, and we have two modalities of surgical therapy: optic nerve sheath fenestration and shunts, lumboperitoneal and ventriculoperitoneal. Optic nerve sheath fenestration, also called ONSF, is indicated in patients with predominantly visual issues. ONSF has a less systemic morbidity than shunts, but there is a higher risk of injury to the optic nerve or associated central retinal artery and central retinal vein. Shunts are indicated in patients with predominantly headaches and or cranial nerve 6 palsy, but there is a higher risk of systemic morbidity with a lower risk of optic nerve injury. Stenting of a collapsed transverse sinus can also be done if detected. The major sequela of idiopathic intracranial hypertension or raised intracranial pressure itself is optic nerve damage. So this is very important, and that is where the role of ophthalmologist comes. Other symptoms and signs of IIH are self-limiting. So what is the ophthalmologist's role in management? Regularly scheduled follow-up to document the visual acuity, color vision, disc photos, visual field defects and OCT. OCT we have discussed in a previous session. So during resolution of papilledema, the p-RNFL thickness decreases, and if there is no axonal damage, the GC-IPL thickness remains intact. If there is axonal damage, the GC-IPL thickness declines. The ophthalmological findings are crucial for the neurologist and the neurosurgeon to determine the course of treatment. Now we come to the next section, the inflammatory optic neuropathies, and there can be various etiologies. It can be an isolated inflammatory optic neuropathy, it can be associated with demyelinating neuropathies, a very important topic, or it can be associated with other local or systemic inflammatory diseases or infection. Now we may have a retrobulbar neuritis when the posterior portion of the optic nerve is affected, but the ONH appears normal, and it occurs mostly in demyelinating diseases. Or we may have a papillitis when the optic nerve head is predominantly affected and it appears edematous and diffusely hyperemic, and it occurs mostly in post-viral and other infective etiologies. So coming to acute demyelinating optic neuritis, it occurs most commonly in young females, but any age and sex may be affected. So it can be isolated, also known as CIS or clinically isolated syndrome, or associated with another demyelinating disease, most commonly multiple sclerosis. So what are the symptoms? The patient has loss of vision, and the loss of vision is subacute. The vision decreases only for several days, and it is monocular usually. There is periorbital pain on eye movement. This is very important, periorbital pain on eye movement, and this may precede vision loss. There is worsening of symptoms with exposure to heat or during exercise, called an Uthoff symptom. Photopsias can occur, and recovery happens within 4 to 8 weeks. The severity of the initial visual loss is related to the final visual outcome. So what are the signs? The patient has dyschromatopsia or abnormality in color vision, particularly the red-green axis, but the blue-yellow axis is also involved. There is loss of contrast sensitivity as well as loss of brightness sensitivity. These are almost universally present. So color vision, contrast sensitivity and brightness sensitivity problems happen almost universally, and they are often more severe than loss of visual acuity. Unilateral presentations have RAPD. Normal appearing ONH, that is retrobulbar neuritis, occur in 2/3 of patients, and hyperemic ONH happen in remaining 1/3 of patients. So in 1/3 of patients, the optic nerve head itself is involved, called optic neuritis, and in the remainder 2/3, the retrobulbar part of the optic nerve is involved, and it is called retrobulbar neuritis. The visual field abnormality in half of the patients is a central scotoma. Others, however, may have a variety of defects. Optic neuritis in children have more severe visual loss, have bilateral involvement frequently, and have ONH edema more commonly. Here we must remember that hemorrhages are very uncommon in optic neuritis involving the optic nerve head. Now this is a very important trial, optic neuritis treatment trial, which gave us a lot of insight into optic neuritis and associated multiple sclerosis. So ONTT has found that overall 35% had recurrence in the same or fellow eye. Little more than a third of the patient had recurrence, but 48%, almost half, among those who have converted to MS had recurrence of optic neuritis. Majority, 90% or more, regained visual acuity of 6/12 or better. So the prognosis as regards visual acuity is very good. However, majority are still aware of subtle visual abnormalities long term, which can be detected by tests assessing color vision, contrast sensitivity, stereopsis and visual fields. So how do you work up a patient with suspected optic neuritis? An MRI should be done in every case. MRI shows enhancement of the optic nerve, usually a short segment, and periventricular white matter lesions on T2 or flared. We have seen periventricular white matter lesions picture in the previous session. However, for this, look up in the internet for an image because I couldn't find a non-copyrighted image. These periventricular white matter lesions in the brain are 3 mm or more in diameter, usually ovoid and usually radiating towards the ventricles. Within 15 years, the risk of conversion to MS varied from 1/4, 25% of optic neuritis patients with no brain lesions. So that is where the role of routine MRI brain imaging comes in optic neuritis. And if we find at least one lesion in the MRI of the brain, there is a 15-year risk of converting to multiple sclerosis in 78% of patients. However, patients with more lesions compared to those with a single lesion were not significantly at still higher risks of converting to multiple sclerosis. Conversion usually occurs in first 5 years, and among those not converting within the first 10 years, only 2% converted in the next 5 years. This is also a ONTT finding. OCT we have discussed in a previous session. Initially it is normal in retrobulbar neuritis other than thickening if it is a papillitis, and few months after onset p-RNFL thinning starts, and thickness less than 75 micron is found within 3 to 6 months of onset, and these identified patients who will likely have persistent visual dysfunction. Coming to treatment of optic neuritis, corticosteroid therapy has no effect on the final visual acuity, an ONTT finding. Intravenous methylprednisolone shortens the recovery time by 1 to 2 weeks, an ONTT finding, the effect being greatest if started within 15 days of onset. This intravenous methylprednisolone is given for 3 days, followed by oral prednisolone for 11 days. However, treatment should not be started with oral corticosteroids alone because it doubles the recurrence rate. So 30% in oral steroids group versus 13% in intravenous methylprednisolone group in 2 years, and 44% in oral steroid group versus 29% for IV-MP group in 10 years. So this is very important to remember. Never start treatment with oral corticosteroids. If we do not wish to give intravenous steroids, it is better not to give any therapy at all. In patients with 2 or more periventricular white matter lesion, intravenous corticosteroids reduce the risk of conversion to MS. So this is another role of intravenous corticosteroid. It reduces the risk of conversion to multiple sclerosis from 36% to 16% in the first 2 years. But by year 3, this effect is lost. This is an ONTT finding. Recent reports have shown that megadose oral steroids, 1250 mg prednisone per day, compared to usually what we give 80 to 100 mg per day for 3 days followed by the routine dose, reduces recovery time without increasing risk of recurrence. So this is a recent finding. Megadose oral steroids, almost 10 times or more than that which we give in usually orally. Following corticosteroid therapy in patients with higher risk of progression to MS, that is who show 2 or more MRI lesions or who show oligoclonal bands in CSF analysis, one of the following medications should be considered long term to reduce the risk of future multiple sclerosis. These drugs include interferon beta 1A, interferon beta 1B and glatiramer acetate. So these are the drugs and the trials which showed their benefit. Diagnosis of MS is based on the following. We have attacks clinically and we have lesions on MRI, and these are both separated in time and space. That means they are remitting and relapsing. These attacks involve the sensory motor and cerebellate system, and the lesions are corresponding to the attacks. Cranial nerve 5, 6 and 7, which are related to the eye, may be involved. However, 10% of MS have primary progressive disease and they do not have remission and relapses. And on CSF analysis, we find oligoclonal bands. So what are atypical optic neuritis or atypical presentation of optic neuritis, which require further evaluation and which may have a lower risk of MS? But lower risk of MS does not automatically indicate a better prognosis, as we will shortly see. So they present in older patients. In male sex, have a bilateral presentation. The vision is no light perception in some of these cases. They lack periorbital pain. Progressive loss of vision occur beyond 1 week of onset. The optic neuritis, which has not started improving within 4 weeks of onset, which relapses after withdrawing steroids, and which have significant ONH swelling with peripapillary hemorrhaging and exudates and involvement of other cranial nerves. Here we must remember that lack of periorbital pain, progressive visual loss beyond 1 week of onset, and visual loss which has not started improving within 4 weeks of onset indicate atypical optic neuritis, and these are very important clues clinically. So investigations which are indicated for atypical optic neuritis include neuromyelitis optica, myelin oligodendrogliocyte associated disease, Leber hereditary optic neuropathy, intracranial space occupying lesion, meningeal inflammation and infiltration, tuberculosis, syphilis, Bartonellosis, sarcoidosis and connective tissue disorders. Inflammations and infections of the optic nerve head can involve other layers of the retina. Sarcoidosis may have a lumpy white appearance of the optic disc, a very characteristic presentation, and connective tissue diseases such as systemic lupus erythematosus, polyarteritis nodosa and vaganus can also present with optic nerve involvement. So what are the differential diagnosis of optic neuritis? We have acute ischemic optic neuropathy, which presents usually in an older age group, is painless, have peripapillary hemorrhages which are very uncommon in optic neuritis. Field defects are usually altitudinal. We have delayed optic nerve head filling on fluorescent angiography, and MRI does not show ON enhancement. In compressive lesions, we find vision loss progressing beyond 2 weeks of symptom onset. So para-infectious optic neuropathy starts 1 to 3 weeks after a viral fever or vaccination. They are frequently bilateral, more common in children, and may or may not have ONH edema. They may also have neuroretinitis if there is ONH edema. They also may have associated meningoencephalitis, and visual recovery is excellent even without treatment. Neuromyelitis optica or Devick's disease is another cause of optic neuritis, and here the optic neuritis can be unilateral or bilateral on presentation, and there is also longitudinally extensive acute transverse myelitis. Now this optic neuritis and longitudinally extensive acute transverse myelitis may occur simultaneously or separately. Longitudinally extensive is an important term, which means several segments of the spinal cord are affected at once. Optic neuritis in NMO is profound, bilateral, recurrent and does not improve spontaneously, in contrast to the MS associated optic neuritis. The enhancement of the optic nerve in MRI in NMO is also longitudinally extensive, so it involves a longer segment of the optic nerve. Now there are other features associated with neuromyelitis optica, and they are called NMO spectrum disease or NMOSD. And the core clinical features associated with NMO are acute diencephalic syndrome or midbrain syndrome, which present with narcolepsy, hypothermia, hypotension, bradycardia, hyponatremia. Area postrema syndrome. Area postrema is located in the floor of the fourth ventricle in the medulla oblongata, and area postrema syndrome manifests with hiccups, nausea and vomiting. Acute brainstem syndrome may also occur with dysarthria, dysphagia, diplopia, facial palsy and quadriplegia. And acute cerebral syndrome consists of confusion, decreased mental status or seizures. So optic neuritis and acute transverse myelitis may be associated with a large number of other symptoms in NMO. So the lesions in MRI corresponding to symptoms are found, including longitudinally extensive involvement of the spinal cord, as we have discussed. In the serum we find immunoglobulin G against aquaporin 4. This aquaporin 4 is found in astrocytic food processes along the blood-brain barrier, and this IgG to aquaporin 4 is highly specific for NMOSD. Treatment involves high-dose intravenous methylprednisolone, plasma exchange and intravenous immunoglobulin, azathioprine and biologics like rituximab, eculizumab and inebilizumab. Since it causes inflammatory necrosis of neural tissue, so NMO causes necrosis of the tissue. Visual and neurologic prognosis is poorer than MS, particularly if the disease is recurrent. Severe visual impairment is common in at least one eye. In a patient presenting with optic neuritis, it is important to detect NMOSD symptoms and signs, the core clinical features. As we have discussed in the previous slide, since NMO does much better if intensive treatment is started in the very beginning of symptom onset, then we have another entity called MOGAD, that is myelin oligodendrocyte glycoprotein IgG associated disorder. This is characterized by optic neuritis, myelitis and encephalitis. So in addition to optic neuritis and myelitis, we also have encephalitis. And compared to MS, loss of vision is more severe and bilateral and associated with prominent ONH edema. So this is a feature of MOGAD. However, unlike NMO, visual recovery occurs in the majority of patients. So like NMO, the loss of vision is more severe and bilateral, and unlike NMO but like MS, visual recovery occurs in the majority of patients. 50% patients have monophasic course, that is a single episode, but remaining have a chronic and recurrent course like CRION, which we come to in a subsequent slide. Here also we find longitudinally extensive involvement as well as perineural involvement of the optic nerve, and this perineural involvement of optic nerve extend to the optic nerve sheath and surrounding orbital fat. This is also an important feature of MOGAD. Periventricular lesions are however rare, and in the serum we find IgG to myelin oligodendrocyte glycoprotein. Treatment includes high-dose intravenous methylprednisolone, plasma exchange and intravenous immunoglobulin, mycophenolate mofetil and rituximab. CRION or chronic relapsing inflammatory optic neuropathy is another entity, but it is not associated with MS and it persists for months to years. It is very responsive to but also very dependent on steroids, so the episodes are repetitive, remitting and relapsing. Another entity which can manifest with optic neuritis is GFAP astrocytopathy or glial fibrillary acidic protein astrocytopathy. Here optic neuritis almost always is associated with meningoencephalitis with altered mentation, seizures and ataxia. ONH edema is common with or without raised intracranial pressure. GFAP antibodies can be detected in serum, and treatment includes high-dose IV corticosteroids, plasma exchange and intravenous immunoglobulin. Optic perineuritis is another entity where there is inflammation of the dural sheath of the optic nerve. It occurs more commonly in females but in an older age group. Vision loss is acute and painful. Pain is an important component of the disease presentation, but the vision loss is milder, and the visual field defect is usually peripheral. The visual loss progresses over weeks and does not resolve without treatment. Imaging shows enhancement of optic nerve sheath with tram track sign. Tram track sign is more well known in optic nerve meningioma but is also seen in this entity optic perineuritis. Optic perineuritis is not associated with MS. Optic perineuritis is mostly idiopathic. However, causes include syphilis, sarcoidosis, vaginous granulomatosis, IgG4 related disease and MOGAD. Neuroretinitis presents with acute loss of vision with edema of the optic nerve end and macular exudates in a perifoveal pattern called a macular star. Here in this picture we find the perifoveal exudates in the nasal sector of the perifoveal retina. However, in well-developed cases of neuroretinitis, these exudates occur all around the fovea and is called a macular star. Macular star occurs due to exudates accumulating in the Henle's layer. Henle's layer is made up of the processes of the photoreceptors slanting peripherally from the foveal pit to reach the outer plexiform layer and meet the bipolar cells. And this macular star may take a few days to appear. Neuroretinitis can be anticipated before the appearance of macular star and differentiated from other causes of ONH edema by detecting fluid and exudation in papillomacular bundle and by detecting peripapillary subretinal fluid in the OCT. And neuroretinitis is also not associated with MS. Neuroretinitis can be associated with infectious causes, out of which Bartonella is very important to remember, also known as cat scratch disease or CSD. Neuroretinitis can occur following a viral fever with syphilis, tuberculosis and DUSN. DUSN is a specific parasitic disease known as diffuse unilateral subacute neuroretinitis. Non-infectious causes of neuroretinitis include sarcoidosis, malignant hypertension and leukemia. And neuroretinitis can also be idiopathic. Efficacy of treatment with steroids and antibiotics of neuroretinitis has not been established. Visual prognosis, particularly in Bartonella, is excellent. Thank you for listening.